Hi everyone, welcome back to the Obsgynaecritcare podcast. Today we're going to do episode 5 in my mini tutorial series on patient blood management in obstetrics and gynaecology, which is on intraoperative or intrapartum strategies to decrease blood loss. Now, when I sat down to put this together, I suddenly realised that I'd bitten off a bit more than I can chew, and I've decided to split it up into two categories. So for the first one, we're going to focus on surgical, physical and radiological techniques which you can use to decrease bleeding, which in my humble opinion is where the money is, because these are the things that actually decrease the amount of blood you lose. And so what we're talking about here in regards, if we refer to the theory of patient blood management, is Pillar 2, minimise blood loss. So to get it started, I thought just a quick reminder that if you're ever in a situation where there's catastrophic bleeding and you need to buy some time, just about all obstetric and gynecological bleeding does come from the pelvic vessels and the pelvic organs, and a great technique for us to know is the manual aortic compression. Go back and have a look at episode, I think it's 2 or 3, where I talk about this in a bit more detail, and there's the link to the great YouTube video done by Dr. Sorensen. Okay, so let's get on to surgical techniques. So this isn't my area, I'm an anaesthetist, but I just want to summarise some of these different techniques that we have available, and hopefully this will inspire you, if you're interested, to go away and delve a little bit deeper. Obviously we can't discuss things in too much detail because unfortunately I've been advised by a number of people, mentors and such, that the sort of sweet spot for these short teaching sessions is about 15 minutes, and that, you know, in modern society we're all time poor, and if I go on for any longer than that, I'm likely to lose everyone's interest. So in the interests of being efficient, we're just going to sort of brush over these things, and hopefully I'll inspire you to go and look into them into more detail. So surgical techniques, a lot of this is all basic stuff, and all people who undergo surgical training are taught all these things as part of their basic skill set: packing, pressure, sutures, removing the bleeding organs like the uterus, performing hysterectomy, clamping off vessels that supply these organs. Learning how to do a compression suture like a B-lynch is a very useful technique if you're an obstetrician and the abdomen is open, for example at the time of caesarean. Uterine artery ligation, I'm told, is also a very useful technique, and I have seen it used very successfully as an anaesthetist peering over the drapes. I've managed to find a couple of YouTube links to some teaching videos for that, but there's actually a whole heap of them there, and feel free to look for them yourself. Balloon tamponade, probably the most commonly used technique. The Bakri balloon is the one that I've seen used the most. Infiltration with vasoconstrictors. Now, maybe this is not something that everyone is familiar with. We'll talk about that in a second. But this is certainly useful, I think, in some gynecological surgery, especially things like myomectomy and removal of fibroids. And increasingly in modern surgical practice, it appears that topical hemostatic methods are being more and more used by many people, and they seem to be very effective, and I think they're possibly a lot more useful than people realise. So topical agents can be composed of many different substances. Generally, I think the basic underlying principle for these things is that as well as providing a physical structure, they have substances in them which stimulate blood clot formation. So that can just be things like cellulose. Some of them also contain things like thrombin, anion, fibrinogen and things like that, which are also components of forming a blood clot. This is a really useful technique for sort of diffuse bleeding from mucosal surfaces or large areas where, putting in a single suture or tying off a vessel is not an option. Vasoconstrictor infiltration. So we use, in the hospital I work in, we use injection of a dilute vasoconstrictor substance injected around the fibroids at the time of myomectomy. And this is a really, in my personal opinion anyway, a very successful and useful technique. Probably the most widely studied in fibroid surgery is the use of vasopressin, and there's a Cochrane review on that. But I have also seen dilute noradrenaline used, probably a shorter acting drug, so maybe the vasoconstrictive effects are a little shorter acting. And also adrenaline, people have used that for a long time. Yeah, things like Marcaine and adrenaline is used quite widely in all areas of medicine. For those of you who are interested, don't take this at face value. You have to go away and check your own institution and look up your own protocols. But this is just to give you a rough idea. This is how it is done at my institution. 20 units, which is 1 ampule of vasopressin, is placed in 200 ml of saline to provide a dilute solution. And the maximum dose that can be infiltrated is 50 ml, which is quite a lot. And that can be repeated at 45 minutes. Things to look out for. So this, you still have to be careful when you do this. Make sure you aspirate before you inject. Obviously, if the needle accidentally goes intravascularly, you'll be giving a bolus of a vasoconstrictor, which can cause some quite interesting changes in the patient's circulation. And so you should always let the anaesthetist know that you're about to do it. I have certainly been aware of patients who've had adrenaline injected at the time of gastroscopy. I've seen some really exciting changes in patients' blood pressure and heart rate when that has gone intravascular. All right, so as well as some of the other surgical things that surgical and physical techniques I've mentioned, what about interventional radiology? I think just find it amazing the amount of progress that's been made in this area in the last 20 years, and it seems that there is no end in sight to all the different types of bleeding that interventional radiology techniques can now treat. So traditionally in obstetrics and gynaecology, patients who have had persistent bleeding have had embolization of the uterine arteries by radiological techniques. And some of the other techniques that have been utilised include prophylactic balloons placed in the uterine arteries or the iliac vessels prior to things like percreta surgery. Very useful. And a more modern technique is, or more recent technique, is probably the correct phrase, is something called reboa, which when I first heard I thought was a South American reptile, which unfortunately that's not the case. It in fact is an acronym which stands for retrograde endovascular balloon occlusion of the aorta. This has been used increasingly in trauma in some centres to decrease sort of life-threatening bleeding from trauma. And it's also utilised in vascular surgery, and there's some case series out there which I'll try and find the references for where it's been used in obstetric and gynecological bleeding. So that is includes things like accreta and percreta surgery, but also ectopic bleeding and obstetric hemorrhage from uterine and other causes. So if you are lucky enough to have good access to a clever interventional radiologist, then these are some really useful things to utilise. And maybe we'll try and get someone, I'll try and see if I can get an interventional radiologist to come on and give us a bit of a more in-depth discussion on this topic.